At Arizona State University, we've made online education better, smarter, and more personalized so you can go further in your aspiring field.
I decided to pursue medicine once I realized that ASU did have the online program for biological sciences. You're still required to learn the same curriculum. You're still being tested on the same content that anyone would be tested on in person. The comprehensiveness of the program prepared me so well for medical school.
Explore over 350 plus programs at asuonline.asu.edu.
Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a guest I have wanted to have on the show for a very long time. So if I had to venture a guess to what diagnosis or what body system diagnosis I see the most in the pediatric emergency department, I would say most commonly infectious diseases. Second, maybe pulmonology related, asthma, pneumonia, URI, etc. And probably one of the more common presentations are ENT presentations. Strep throat, ear infections, foreign bodies, etc. So today I'm going to talk to Jeremy, who's a pediatric otolaryngologist, aka pediatric ENT doctor at Colorado Children's, and we will talk about ENT presentations in the pediatric emergency department. Welcome, Jeremy, to the show. I really appreciate your time. Just so everybody understands, it's a Sunday morning, kind of early, and Jeremy is a very busy surgeon, so I really appreciate your time. I've been wanting to have an pediatric ear, nose, and throat doctor on the show for a very long time, so thank you very much. Let me just, Jeremy, introduce you to the PEM Rules listeners. And you're going to correct me if I'm wrong at any point, please. Jeremy, you're originally from Ann Arbor, Michigan. I was there once, super cold. You went to college at Duke University and completed your medical degree at Washington University in St. Louis, graduating in 2003. You then completed residency in Otolaryngology, ENT, at Washington University and a PEDS ENT fellowship at Cincinnati Children's, graduating in 2010. Is that all correct?
That is.
All right. And currently, Jeremy, you work at Children's Hospital of Colorado as an otolaryngologist, which sounds a lot better than an ENT, by the way. And your work focuses on disorders of the airways and thyroid. In your spare time, I guess you're busy with teenagers and schools and sports activities. Anything else?
Well, that seems to take all of it, for sure.
I know what you mean.
Yeah,
I know what you mean. But thank you again for coming on the show. How are you?
I'm well, thank you.
Again, and I appreciate you coming on the show. If you've listened to the show before, you probably know the first question. First question for everybody, and everybody has their own perspective. What is your definition, Jeremy, of a good pediatric emergency medicine clinician? One who does what?
Well, I have enjoyed my interactions with the PEDS-EM when it feels like we're really functioning more as partners, and less like asking for someone to just carry out some function. So that's what I think are the kind of nicest relationships are kind of based on asking a question and requesting someone help figure out a clinical scenario. That's what those are the ones I've enjoyed the most. Even more than the ones that are just totally set up PTA, 17-year-old PTA, when can you guys drain it? That kind of thing. To me seems a little more transactional than I always kind of wanted. Does that make sense?
No, that makes perfect sense. It goes back to one of my rules that I tell the residents and the fellows: when you call a consultant, always have an assessment and plan. So when I call you guys, when I teach other people to call for consultants, I'm not an ENT, but I'm a physician. I have an assessment. I have a plan. I try to relate the plan. And if you think my plan is wrong, by all means. But I agree with you. I know exactly what you're talking about. I can imagine it's a challenge to be on call and get phone calls like, okay, when can you come? And I totally understand.
Right.
My second question, and you probably, people who are listening probably guessing it by now. A pediatric ENT and a PEM provider cannot possibly have a clinical discussion on anything without talking about acute otitis media, which is the bane of our existence. And it's a very, very big topic, and I feel like it's a big topic that has gone through some changes. You probably know a few years ago, the AP adopted the watchful waiting approach for acute otitis media, which I love, with the notion that majority or significant portion of the infections we see are viral. And we all know antibiotic resistance is a very, very big growing problem. I know of one paper indicated that depending on the age, but in some ages, most cases, up to 85% of acute otitis media are viral. So I was hoping, Jeremy, can you give us more information about it? If I see a child with what looks like, smells like acute otitis media, he or she are healthy, vaccinated, let's say the average toddler at 2 or 3 years of age, or 1 year of age, what are the chances the infection in front of me is a virus versus bacteria? And how crucial is it for the PEDS EM doctor to give antibiotics today? What would you recommend for PEDS EM docs to do in order to kind of not miss the cases of true bacterial otitis media, but be cognizant of the huge problem of antibiotic resistance?
Right. Boy, we could talk for hours about it, and certainly get into stacks of publications about kind of how to guide this treatment. I'm not familiar with the percentage of what would be viral or not. I do think, however, that in the absence of a toxic exam, as your example stated, a otherwise healthy 2-year-old with what seems like otalgia and a URI, that's pretty reasonable to watch and wait or observation, with pain control type approach, rather than a bacterial approach, antibiotic. In the absence of, also, I would say, an exam that seems concerning for bacterial infection. So a red eardrum, a dull eardrum, a mucoid effusion, all look fairly different to me when I'm under a microscope than an acute bacterial otitis media, which really does often have more of a yellow, white pus, mucoid effusion, even bulging of the eardrum. Now, I get an unfair look at those, like in an operating room under general anesthetic, but I don't think an erythematous TM in a URI sick child is necessarily an acute bacterial infection. And I do think that the burden falls upon the ER as well as the pediatricians when it comes to patient and family education from this standpoint, keeping an eye on the kind of broader problem of growing antibiotic resistance, and just the general problem of overtreatment. Does that make sense?
Yeah, no, that makes perfect sense. Again, I tell the trainees all the time, people are worried about global warming. I'm not dismissing global warming. I'm really worried about antibiotic resistance. I mean, it's something that I see all the time. UTI, otitis media, pneumonias now. So I try to be cognizant about my use of antibiotics, and I like what you said. You're kind of saying, putting it together, look at the child if they are URI or what we pediatrician called viral symptoms. Maybe we can hold off on antibiotics today. That's what I do. I think that's reasonable. Thank you for your opinion and for your help. Do you agree, Jeremy? And that's something I came across actually as an attending, never in fellowship. Do you agree with if I diagnose a child with otitis media and he or she have tympanostomy tube, do you recommend we use topical antibiotics? To my understanding, when the tympanostomy tube in place, you kind of have like a pathway to the middle ear, and you can treat with topical antibiotics and save the child the systemic antibiotics and the side effects of them, and again, bacterial resistance. Is that something you recommend?
Absolutely. Topical therapy is the way to go. I think we see a ton of kids who are getting sent back to us. We've placed tubes and they're being diagnosed with bacterial otitis media and sent back to us with like, what do we do now? And they're not having drainage. And to me, those kids are similar to the toddler you used in the first example. They're probably not having bacterial otitis media. In the absence of drainage, they may have a cold and otalgia, but not a bacterial infection that you necessarily need to treat. That said, there are kids where I'm in the office and I'm looking at an open tube, but it's wet and it's coming. But nevertheless, in the setting of an open tympanostomy tube, topical therapy is really first line. There are scenarios in which there is so much otorrhea that someone needs to suction that out, I think, probably so that the medication has a pathway to go, as you mentioned. But I always feel bad when I see these kids back and they've been put on the sequence of oral systemic antibiotic therapy, and they have open dry tubes. I'm not really sure what was being treated.
Excellent. I appreciate that you agree with me. What about sort of under the same circumstances, the child who doesn't have tubes, but clearly has drainage from the ear? He or she, if they correct me if I'm wrong, if I see a child with ear pain, fever, has drainage from the ear, maybe I can, maybe I cannot see a perforation, but likely there is a perforation. Because can these kids go on topical treatment?
I think they can, although those are the kids where I would likely prescribe an oral antibiotic as well. Yeah.
Oh, so some hydrogen peroxide to maybe melt the pus, topical and oral?
Topical and oral. Hydrogen peroxide, as it bubbles off, I think turns to water, which I don't know that I love putting that deep down in the ear canal. But maybe one suctioning followed by some ofloxacin or ciprofloxacin, dexamethasone course. I have a feeling when there's a spontaneous perforation, such as what this child must have experienced, that those are pretty small holes and they're going to close relatively quickly. So in my mind, the systemic oral therapy is likely the better way to go if I had to choose between the two.
Got it. Moving on with age again, I guess. One of the other things that I see a lot in the PZR, and I don't know why more so in Vegas, again, in my attempt to reduce CT scans and unnecessary testing in the ER, if I see a teenager, sore throat, hot potato voice, fever, dysphagia, etc., one tonsil larger than the other, is CT neck to look for peritonsillar abscess, and I would consider CT neck, I would consider the neck an organ that is fairly radiosensitive. Is that really necessary? Would you accept, so to speak, a phone call from an EM doctor and treat the child without CT neck for what seems like peritonsillar abscess? Would an adult ENT do the same? Do you need any labs before we call you for those guys? I agree in general that draining peritonsillar abscess is considered within the scope of PEM providers. In reality, I don't believe most PEM providers do that. What are your thoughts on that?
So, yeah, I agree with you to take the second part of that first, that no, I don't think you need labs, and no, I don't think you need a CT scan. Now, that's in the setting of a PZR physician examining a patient, story sounds good, and there's soft palate fullness, a deviated uvula, fever, sore throat, strep positive, what have you. That's that's a PTA. We didn't customarily get CT scans on those. That's okay to call and have a discussion and consultation and assess and either needle aspirate and or incision and drainage by whomever is comfortable with. I think that's a PEDS approach, and certainly our ER is cognizant of not scanning and then calling us. I think that they certainly have the same approach where the effort is to not radiate for something that is a clinical diagnosis. The difference comes up, and this is not an infrequent thing, I'm sure you see this as well, where one tonsil is quite swollen, soft palate looks fine. Maybe they're sick appearance similar to a PTA, but there may be more of an intratonsillar problem. And that's a little trickier because what I have seen, now this is all retrospective, is that those CT scans sometimes show phlegmonous changes and or an outright abscess within the tonsil itself, not in the soft palate, not in those smaller glandular areas that are in the superior portion of the tonsil fossa into soft palate, where that's a PTA, but actually an intratonsillar problem. And those are a little trickier because sometimes those kids will get better on IV antibiotics, but they may wind up getting admitted to the PED service and given some time. Occasionally, we will needle aspirate those in either the ER, depending on age and tolerance, or in the actual operating room to kind of give them a good push in the right direction. So I think when the story is not so much an overt PTA, a CT scan is actually pretty reasonable.
All right, very good. That's a very good distinction for us to know. Thank you for that. Briefly, and I know that changes sometimes, what would you recommend for the best antibiotics for those kids before I call you guys?
Well, we use Unison, is customarily our request. This is usually a fairly treatable strep species, at least if we obtain a culture.
Excellent. All right, perfect. Thank you. Next topic, Jeremy, and this is the one I'm curious about the most. This is kind of like, again, something that doesn't come up very, very often, unlike the otitis media and the peritonsillar abscess. But in the winter, we see a lot of children with stridor. It's almost always a 3-year-old boy with viral croup. But every once in a while, and again, this didn't happen to me many times, but I think those are the patients that scare us the most. We see a child that just kind of, the story is different, the exam is different. Over the years, I've seen a few cases of a foreign body, very few cases, maybe 1 or 2 of bacterial tracheitis. And those are certainly not patients we want to miss. Do you have an answer for us, or tips for us about how do we try not to miss those kids with unusual causes of stridor in the sea of viral croup?
Yes, big topic. First thing I would start with, I guess, is viral croup. Usually not sick for too long, not sick for weeks, toddlerish in age. May not always respond as we've discussed to 1 dose of a steroid. I don't typically see this typical croup, like it doesn't even sort of reach us.
Right.
It reaches you folks, it reaches the pediatricians. Our consults are frequently the atypical croup as you're presenting it. The thing you don't want to miss, it may not be atypical. It's I'm not sure what else this might be. And I find that consultation, this discussion, is really common. So I think once it hits the door downstairs in the ER, it's now pretty typical for me and you. This is what we have to figure out. I still find that most of this is steroid responsive, probably undertreated, not willfully undertreated. Just this needs more steroids. This may need racemic. Maybe it's not para-influenza. Maybe it didn't, as I mentioned, read the Cochrane review on what it should do or should not do. But that's a very common situation to be in. So I tend to start these conversations with, let's give them more airway dose steroids. The other thing is the things to not sort of miss. The bacterial tracheitis, the potential for a foreign body. I think some of those things truly look just a little bit different. The BT kids being sicker longer, toxic looking, not well. Again, kind of a wet cough. Perhaps they're a little older. Maybe they're tender over their neck. Some of the physical exam stuff that you and I we were trained about, we've read about. This is what we're supposed to keep looking. Again, suspicion would lead this to an admission, starting an antibiotic. Again, as I mentioned, I think Unison is an appropriate first place to start for some of these kids. And I like to get, if there's a question, even going back to the atypical Kruper in the ER that we still think is viral related, a 2 view of the neck. The 1 view confirms what you're thinking. The lateral will at times hint at membranous exudative badness in the airway. And I think that that's a nice thing to have if your folks are suspicious and you're calling a consult. I've already got the lateral neck. It looks nice and smooth. We all look at it together. I'm a little reassured. But these are actually kids where if we're going down the road of this is an unusual thing, we're probably going to flex scope them in the ER or on the floor. And that's, I think, part of the deal, as you folks know, when you call us, is this is a tool we are likely to use. You may want to tell the parents, we're going to as well, but if we scope them, they're aphonic and we see a bunch of debris, if we can get that view, now we've got a lateral neck that's hinting that there's crusty stuff down there. I feel more reassured if this has been a 2-week illness. This kid's probably going to the unit on racemic, steroid, and Unison, with the potential for us to need to pull that stuff out if they don't get better. That's an algorithm branch that I think is safe to use, because I'd rather do that and, like an appy, occasionally overtreat than be wrong or miss it, so to speak. Now, that said, I think bacterial tracheitis is one of those words in medicine that get a lot of people excited, but that are actually infrequently seen, and or actually maybe not as hard to manage as we've been led to believe. There are some real bad ones out there, like the Ludwig's angina, the epiglottitis, where we're all going to hustle. But bacterial tracheitis, I've operated on a couple times in 15 years, maybe. A lot of these kids will get better when we go down that algorithm. They're in a monitored setting, they're on an appropriate antibiotic, and they will do okay without us actually pulling stuff out of the airway. In fact, disrupting all of that stuff may lead to an intubation, and we've got raw tissue, and now we're in a worse spot than we might have been. So, it's kind of like, I'm sure you folks think about it. If I call somebody, these are the things that somebody can do. They may do it. And not all of the time is that better than the conversation and the medical therapy and so on. And that's on us too, as your consultants, to not overtreat and not necessarily overreact. So there are BT kids where it's been beneficial to pull out a bunch of membranous exudative stuff. But a lot of even these littler ones, if the presumption is that what we're dealing with and we treat it appropriately, they're going to get better. And you've called the NT and we've kind of confirmed we're thinking the same thing you're thinking. And the unit will confirm and treat and they'll be okay. Yeah. And then I think this is a long explanation, but I always think about foreign body in toddlers. I don't trust them at all. It's like, the drill. These little people are they're accidentally trying to hurt themselves kind of all the time. So there's the rare things, but a inspiratory expiratory film, the lateral neck film that I mentioned earlier, if it will occasionally catch like a Kruper who looks fine otherwise, that's a subglottic lesion, maybe a hemangioma, occasionally responds to a dose of steroids, but then comes back, something's not quite right. Great consult. Sometimes you'll see that swelling on the 2 view of the neck again, and those kids are going to go down a different branch of the algorithm. And then there's the epiglottitis kids, thankfully super rare. We tend to scope those kids in the ER. Sometimes they've come in with not necessarily an outside scope, but a CT scan or a 2 view of the neck that can hint at things. But if they're not actively desatting and having like OR type trouble, we'll scope them in the ED and come up with a plan with our anesthesia colleagues.
Excellent. Well, thank you very much, Jeremy. Those are really excellent tips from the expert, and again, something that sits high on my list of I never want to miss it. And again, I don't see that very often, but every once in a while, bacterial tracheitis is in my differential, and that's not a good situation for the child. So having you guys is super helpful. I want to thank you, Jeremy, for your time. And again, we're going to follow the PEM rule tradition. I do all the music in the podcast. I'm very proud of that. And you wanted to hear a song by the Grateful Dead. Is that right?
I did.
Tell me about that, because I know nothing about the Grateful Dead. I'm happy to adopt.
So, you can get real into this stuff, and I am moderately into it for a long time now. But the music's terrific. There are fans for particular years, particular seasons, who was in the band, who wasn't. It's just amazing. And the amount of the music catalog that is available, that is nearly exclusively live, is really terrific. So I chose one called Ripple because it's really a nice little guitar tune and written by really their poet lyricist. So enjoy.
All right. I guess I'm going to have to learn Ripple by the Grateful Dead.
Yeah.
Thank you, Jeremy, very, very much for coming on the show. I really, really appreciate it. And, hopefully if we can have you again.
I'd love to. Thank you very much.
Thank you. Thank you very much. And that is it for today, guys. As always, thank you for listening to PEM Rules. Please check out the Facebook. Continue writing to me. I really like hearing from you guys. If there's a topic you want to hear, if you want to come on the show and present, talk about any PEM-related topic whatsoever. If you're a trainee, you might be able to get some credit for your scholarly activity. I leave that to your residency or fellowship director. By all means, everybody's invited so we can all learn from each other. Thanks again for everything, and this is Ripple by the Grateful Dead. Best attempt to do so. Hope you like it. Have a great day.